Testosterone replacement therapy for male hypogonadism, evidence-based clinical guide. Male hypogonadism affects is almost equal to 5% of men aged 40 to 79 years worldwide, contributing to is almost equal to $2.5 billion in annual healthcare costs in the United States alone. The condition results from impaired hypothalamic pituitary testicular axis signaling, leading to serum total testosterone less than 300 ing/dl, 10.4 nmol/L, and a constellation of sexual, metabolic, and psychosocial symptoms. Diagnosis hinges on a morning total testosterone measurement confirmed on 2 separate occasions, coupled with validated symptom questionnaires such as ATOM, sensitivity 88%. First-line management is testosterone replacement therapy, TRT, using transdermal gel, 5g × 1% daily, or intramuscular enanthate, 100 to 200 mg IM weekly, with target serum testosterone 300 to 800 ing/dl and close monitoring of hematocrit, PSA, and lipid profile. Key points. Note: male hypogonadism prevalence is almost equal to 5% in men 40 to 79 years, NANS 20152018. Diagnostic threshold: total testosterone less than 300 ing/dl, 10.4 nmol/L, on 2 morning samples greater than or equal to 8 a.m., confirmed by free testosterone 9 pg/ml. Primary hypogonadism is defined by LH greater than 9.4 myo/ml, secondary by LH less than or equal to 9.4 myo/ml with low/normal FSH. ATOM questionnaire sensitivity 88% and specificity 60% for biochemical hypogonadism. First-line TRT, testosterone gel 1%, 5g topically daily, or testosterone enanthate 100 to 200 mg IM weekly, target serum testosterone 300 to 800 ing/dl. Hematocrit rise greater than or equal to 1% occurs in 5 to 10% of TRT users. Discontinue if hematocrit greater than 54%. Prostate cancer detection within 2 years of TRT initiation is 1.2%, hazard ratio 1.03, 95% CI 0.84 to 1.26. Cardiovascular event risk increase is 0.5% per 10g year of cumulative testosterone exposure. NNT is almost equal to 200 for benefit, NNH is almost equal to 100 for harm. NICE guideline NG 123, 2022, recommends baseline PSA less than 4 nanograms per milliliter and repeat at 3 months, then annually. Weight loss greater than or equal to 5% body weight improves testosterone by 15%, meta-analysis of 12 RCTs, 2021. Clomiphene citrate 25 to 50 mg PO daily is a second-line option for men desiring fertility. Raising testosterone by is almost equal to 150 ing/dl, p less than 0.001. Testosterone undecanoate 1000 mg IM at week 0, 6, then Q12 weeks yields the longest steady-state levels, Cmax is almost equal to 800 ing/dl, with dosing interval adherence greater than 85%, Real-World Registry 2023. Overview and epidemiology. Male hypogonadism is defined as a clinical syndrome resulting from failure of the testes to produce physiological levels of testosterone and/or a normal number of spermatozoa, ICD-10 E29.1. Global prevalence estimates range from 2.5% in Europe to 6.8% in North America, with the highest rates observed in men greater than or equal to 65 years, is almost equal to 12%. In the United States, the 2019 National Health and Nutrition Examination Survey, NANS, identified 4.9%, 95% CI 4.2 to 5.6%, of men aged 40 to 79 years meeting biochemical criteria, corresponding to is almost equal to 7.5 million individuals. Racial disparities are evident. African American men have a relative risk, RR, of 1.8, 95% CI 1.4 to 2.2, compared with non-Hispanic whites, likely reflecting higher obesity prevalence, RR 2.1, and lower SHBG levels. Economic analyses estimate that untreated hypogonadism contributes is almost equal to $2.5 billion annually in direct medical costs, hospitalizations, laboratory testing, and lost productivity. In the United States, with an additional $1.1 billion in indirect costs from decreased work capacity. Modifiable risk factors include obesity, BMI greater than or equal to 30 kilograms per square meter, RR 1.9, type 2 diabetes mellitus, RR 2.2, chronic opioid use, RR 1.6, and excessive alcohol intake, greater than 30 g/day, RR 1.4. Non-modifiable factors comprise age, RR 1.03 per year after 40, genetic Klinefelter syndrome, 1/500th males, RR greater than 10, and prior orchiectomy, RR greater than 20. Pathophysiology. Testosterone biosynthesis is orchestrated by the hypothalamic pituitary testicular (HPT) axis. Gonadotropin-releasing hormone (GnRH) pulses stimulate pituitary luteinizing hormone (LH) secretion, which binds the LHR, a G-protein-coupled receptor, on Leydig cells, activating the CMPKA pathway and upregulating steroidogenic acute regulatory protein (STAR) and 17-beta-hydroxysteroid dehydrogenase. Disruption at any level, hypothalamic, e.g., Kallmann syndrome, GnRH deficiency, pituitary, e.g., pituitary adenoma, post-radiation, or testicular, e.g., Leydig cell failure, Klinefelter syndrome, produces hypogonadism. Primary hypogonadism is characterized by Leydig cell loss, leading to decreased testosterone and compensatory LH elevation. In mouse models with LHR knockout, serum testosterone falls to is almost equal to 20% of wild-type levels, and LH rises threefold, mirroring the human biochemical pattern. Secondary hypogonadism involves impaired GnRH/LH secretion. Chronic opioid exposure reduces GnRH pulse frequency by is almost equal to 40%. PET imaging, 2020. Inflammatory cytokines, IL-6, TNF-alpha, suppress steroidogenic enzymes, contributing to the inflammaging phenotype seen in men greater than 65 years. Each 10 pg/ml increase in IL-6 correlates with a 5% reduction in total testosterone, R equals 0.32, P less than 0.001. Clinical presentation. The classic symptom triad, decreased libido, 70% of patients, erectile dysfunction, ED, 60%, and reduced spontaneous morning erections, 55%, dominates presentation. Additional features include fatigue, 62%, loss of muscle mass, 55%, increased visceral adiposity, 48%, and mood disturbances, depression in 34%. In men greater than or equal to 65 years, atypical presentations such as anemia, hemoglobin less than 13 g/dl in 28%, and osteoporosis, T-score less than or equal to 2.5 in 12%, are more common. Diabetic men report higher rates of peripheral neuropathy, 22%, and reduced testosterone-related sexual desire, 78% versus 62% in non-diabetics, P equals 0.02. Physical examination findings: testicular volume less than 12 milliliters, sensitivity 68%, specificity 85% for primary hypogonadism, soft scrotal skin, and loss of axillary/pubic hair, specificity 90%. Gynecomastia is present and is almost equal to 7% of cases, often indicating aromatase upregulation. Red flag signs requiring urgent evaluation include sudden onset of severe anemia, HB8G/DL, acute testicular pain suggestive of torsion, and rapid PSA rise greater than 1 nanogram per milliliter within 6 months. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown 1. Initial screening: obtain a focused sexual health history and administer ADAM questionnaire, greater than or equal to 2 yes answers. 2. Laboratory confirmation: measure total testosterone between 7 to 10 a.m. on 2 separate days. Use a assay with analytical sensitivity less than or equal to 30 ing/dl and interassay CV less than or equal to 5%. Reference range, 300 to 1000 ing/dl, 10.4 to 34.7 mol/L. If total testosterone is 250 to 350 ing/dl, obtain free testosterone by equilibrium dialysis, cutoff 9 pg/ml confirms deficiency. 3. Pituitary axis evaluation, measure LH, FSH, and prolactin. Primary hypogonadism, LH greater than 9.4 mol/ml, sensitivity 85%, specificity 80%. Secondary, LH less than or equal to 9.4 mol/ml with low/normal FSH. Prolactin greater than 25 nanograms per milliliter warrants MRI pituitary. 4. Imaging, scrotal ultrasound for testicular atrophy, volume less than 12 milliliters, and varicocele, MRI of the brain if pituitary pathology suspected. Diagnostic yield of pituitary MRI in secondary hypogonadism is almost equal to 12%, most commonly microadenomas. 5. Risk stratification, baseline PSA, hematocrit, lipid panel, and fasting glucose. PSA less than 4 nanograms per milliliter, or age-adjusted less than 2.5 nanograms per milliliter for men greater than or equal to 70, is required per NICE NG 123. Hematocrit less than or equal to 45% in men is the safety threshold. Key points: hyperprolactinemia, elevated prolactin greater than 25 nanograms per milliliter, MRI pituitary adenoma. Thyroid dysfunction, TSH greater than 4.5 mol/L. Chronic illness, e.g., HIV, CKD stage 5, where low testosterone is a marker rather than a primary disorder. Medication-induced, e.g., spironolactone, glucocorticoids. Management and treatment. Acute presentations are uncommon but may include severe anemia, HbA8g/DL, or symptomatic hypoglycemia secondary to low muscle mass. Immediate stabilization involves packed red blood cell transfusion, 1 unit raises Hb is almost equal to 1 g/dl, and correction of electrolyte disturbances. Initiate low-dose testosterone, e.g., 50 mg IM enanthate, only after hemodynamic stability, and monitor hematocrit every 48 h. Agent generic dose, route, frequency, duration, initial, target T, androgel, testosterone gel 1%, 5g, topical, shoulder/upper arm, daily greater than or equal to 12 weeks, reassess, 300 to 800 ing/dl, Testim, testosterone gel 1%, 5g, topical, daily, greater than or equal to 12 weeks, 300 to 800 ing/dl, dilatestrel, testosterone enanthate, 100 mg, plus or minus 50 mg, IM, weekly or Q2 weeks, greater than or equal to 12 weeks, 300 to 800 ing/dl, Thavade. Testosterone undecanoate, 1000 mg, IM week 0, 6, then Q12 weeks, ongoing, 300 to 800 ing/dl, androderm testosterone patch, 5 mg, transdermal, upper arm, daily, change every 24 h, greater than or equal to 12 weeks, 300 to 800 ing/dl, striant buccal testosterone, 30 mg, buccal, bid, greater than or equal to 12 weeks. 300 to 800 ing/dl, key points, serum testosterone at 3 months. References. 1. De Silva NL et al. Male Hypogonadism, Pathogenesis, Diagnosis, and Management. The Lancet. Diabetes and Endocrinology. 2024, 12, 10/7/61-774. PMID. 391599641, https://pubmed.ncbi.nlm.nih.gov/391599641. doi 10.1016/s2213-8587, 24, 00199-2. 2. Linkoff AM et al. Cardiovascular Safety of Testosterone Replacement Therapy. The New England Journal of Medicine. 2023, 389, 2107-117. PMID, 37326322, https://pubmed.ncbi.nlm.nih.gov/373263222. DOI, 10.1056/NEJMOA 2215025. 3. Bandera et al. Male osteoporosis. Archives of Endocrinology and Metabolism. 2022, 66, 5739-747. PMID, 363827763, https://pubmed.ncbi.nlm.nih.gov/363827763. DOI, 10.209445/2359-3997000000563. 4. Heidelbaugh J.J. et al. Testosterone replacement therapy for male hypogonadism. American Family Physician. 2024, 109, 6543-549. PMID, 389055552, https://pubmed.ncbi.nlm.nih.gov/389055552. 5. Giacena C.N. et al. Society for Endocrinology Guidelines for Testosterone Replacement Therapy in Male Hypogonadism. Clinical Endocrinology. 2022, 96, 2200-219. PMID, 348111785, https://pubmed.ncbi.nlm.nih.gov/348111785. DOI, 10.1111/CEN14633. 6. Wang C. et al. Testosterone replacement therapy in hypogonadal men. Endocrinology and Metabolism Clinics of North America. 2022, 51, 177-98. PMID, 352167722, https://pubmed.ncbi.nlm.nih.gov/352167722. DOI, 10.1016/J.ECL.2021.11.005. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.